going. So, Bill, over to you.
Thanks so much, Allison, and thanks to everyone at the Canadian Cancer Survivor Network who help support and put these webinars on. They're a great opportunity for the cancer community to learn about important policy and health system issues that are ongoing, that we read about from time to time in the newspaper, but rarely have a full hour to devote to and drill down on. So really appreciate the listenership as well, everyone who logs on, and as Allison mentioned, get ready with your questions. Even during the presentation that Louise and I are going to give, please start filling in that question box, because we really depend on you and that interaction to make these webinars a success. As Allison said, you can learn more about the CCSN. We're also going to show the Survivor Network's web address and contact information, as well as Louise's as well. So if anyone wants to get in touch offline, please feel free to do so. So with that, let's get started. National Pharmacare, what's happened, where are we headed, and taking stock. This is an issue that goes back 50 plus years now in terms of Canadians discussing and considering what can and should we do regarding pharmacare and access on a national level. There's so much that's happened in that 60 years, and that we're gonna try to distill that right down to what's actually happened in the last year and a half. So let's get started now. Okay. So today's speakers, we've already introduced ourselves. Thank you so much, Allison. Maybe I'll just do a quick intro to Louise Binder, again, because you've just started the recording. A lawyer, longtime health policy expert, and now with the Save Your Skin Foundation. We're so delighted, Louise, that you've brought your the passion and success that you've brought to bear on the HIV and infectious diseases world, now to the cancer world, and working with Save Your Skin on those issues. And there are a few people that have really rallied many different groups together, working with the Survivor Network and other cancer groups to improve the lives of Canadians, especially by working with and sometimes antagonizing and catalyzing some important change at the policy level and the political level. So we're just delighted to have you on the line today. So feel free to jump in throughout this presentation.
Will do.
Okay, so pharmacare in Canada, we're going to start with just a few facts. We'll bring it back to some of the issues around cancer care in particular. We'll discuss what's happening in terms of a pharmacare report or some implementation decisions that could happen over the next few months, and the advisory council that has wrapped up its formal consultations, but hopefully is listening on this webinar. So Dr. Hoskins, if you're listening, please take lots of notes. So let's get started. Pharmacare in Canada, a few facts. First of all, shout out to the Conference Board of Canada, which is run in parallel to what Dr. Hoskins and the Advisory Council have been working on, a National Pharmacare initiative, and they've been commissioning and researching a lot of interesting data on where pharmacare is really challenged in terms of people accessing the medicines that they need. So some of these statistics in the next couple of slides are from the Conference Board. And what they found is that the majority of Canadians have access to drug insurance through private or public plans, or both. And there's often overlap. And a lot of people who are on the line will have access to private coverage, and some public coverage. Overlap in terms of insurance coverage is a pretty common thing. People have multiple life insurance policies, and especially in Canada, about half of all of our health spending, not half, about 30% of all of our health spending does come from our out-of-pocket or private sources. In terms of pharmacare, it's actually even more than that. But all Canadians have access to some form of catastrophic drug coverage, and that's public catastrophic drug coverage. Now, the caveat there is that the medicine has to be on the provincial formulary in most cases to obtain reimbursement. But if you actually go over your a certain percentage of your annual income or your household income, generally you can access medicines. In Ontario, that's the Trillium program, for example. The main issue or the question for the National Pharmacare discussion, I should say questions, is who should provide that first dollar or primary coverage? What does it cover? What does the formulary look like that the beneficiaries of that coverage have access to? Who pays for the coverage? And then what part of that coverage is the responsibility of the patient, or in fact, their employers or some other payer besides government in terms of deductibles, premiums, copays, versus the insurer, either public or private. So these are the kinds of relatively technical and accounting questions that are at issue, and actually where the rubber really hits the road on the challenge of National Pharmacare. So according to the Conference Board, there's approximately 37 million Canadians today. Well, almost 26 million are eligible for a public drug program. 22.5 million are enrolled in at least one private drug plan, and that's usually through an employer plan. Either your children or your spouse or your partner, they can also have access to it. And even there's often overlap. People have access to multiple private drug plans. And then if you add them together, recognizing that there's overlap, around 35.5 million Canadians are eligible for one form of insurance coverage. And eligibility is an important point to make. And I'll just quickly show you a map of uninsured Canadians and where they mainly are. So all of the provinces that are gray on this slide have either a universal plan, such as Quebec and some of the Western provinces, or if you look at a lot of the Atlantic provinces and in Alberta, I'll point them out in particular, at any time they can actually apply for and get access to the public plan. Now, there are co-pays and deductibles, et cetera, but it would be similar to any individual going out and getting access to a private plan. It just happens to be the public plan that they can actually apply for and get access to. What that means is you're going to see some stats show much higher levels of uninsured Canadians, and that is true, but they actually have access to insurance. So if I'm an oil sand contract worker in Alberta, but I'm relatively young and healthy, which I'm not anymore, at least relatively young, I might decide, instead of paying the $900 in deductibles and annual premiums, that I will wait, and if I need it, if I actually have a health issue, I will actually then apply and get access to it. So that's what this map shows. It also shows that the majority of those who are either not eligible or do not have access to a public plan are in Ontario and in Newfoundland and Labrador. And those are still pretty shocking numbers in terms of 600+ thousand Ontarians and an even higher percentage of Newfoundlanders and Labradorians that don't have access to a plan. So that's the issue. But taken in context, over 98% of Canadians do have access or are eligible for some kind of public program. Now, of course, as often is the case, cancer is a bit different, and many cancer treatments are covered through hospital budgets or cancer agencies. And the Western cancer agencies and programs in particular, if you look at this map, and special shout out to Deb Maskins and the team at Kidney Cancer Canada and the Can Certainty campaign that goes way beyond kidney cancer. Really good work that is, I think, paying dividends in terms of changing policy, pointing out this disparity. The Western cancer agencies will cover soup to nuts everything from the antiemetics for chemo-induced nausea and vomiting to injectable cancer drugs delivered in hospitals, and of course the community take-home drugs as well. You have coverage in Western Canada, but if you get into Ontario, and the Atlantic, yes, you're covered in hospitals, but the oral or take-home drugs, you have to pay out of pocket or pay significant premiums to access those through other plans. And the numbers there that they have are mainly because that's how much of your annual income you would have to devote to that take-home drug before the catastrophic drug insurance would kick in, and that's what I talked about earlier. But this discrepancy is something that is one of the potential things that I'm hoping that the National Pharmacare debate will hope rectify. I don't know, Louise, if you want to tag in on that at all before we keep on going.
Well, it's certainly one of the potential inequities that that Pharmacare, universal Pharmacare, could resolve without it becoming too contentious. And I'm going to talk, when I mean contentious, I mean politically contentious. I think that that's the kind of thing that would be an easy fix. I'm going to talk about it in a little more detail about some of the sort of easy fixes and the not so easy fixes when you're done, Bill. But yeah, that's one of the easy fixes, in my opinion.
Excellent. But this time next year, Louise, then we're going to have a new slide, and this will all be fixed, okay?
Okay.
So we'll talk a little bit about National Pharmacare gaining momentum. I mean, we're hearing a lot more about it. It actually makes the news relatively often these days. And just going back to early last year, you saw some provinces, especially Ontario, stepping up and taking the first steps towards what they were hoping at the time under the previous Wynne government would be a bit of a template for national Pharmacare. And that was when the Wynne government, under then Dr. Hoskins, when he was Minister of Health in Ontario, offering prescription medicines for children and youth, so those who are under 25, through something that they called OHIP Plus. And OHIP Plus continues to exist, although it will move to second payer. If you have access to a private drug program, then OHIP Plus may become a backstop as that changes. But what that did do, shortly after that was announced and in place, after it had actually become effective, then Ontario Health Minister Eric Hoskins was named as the chair of the newly created advisory committee on the implementation of National Pharmacare in February 2018, and that was in the context of last year's federal budget in Ottawa. And we'll talk briefly about that, what that advisory committee is doing shortly.
Bill, can I just jump in for a sec?
For sure.
Just to go back to the question of OHIP Plus, I think that we were in some ways very fortunate that Ontario took a risk with OHIP Plus, because it was a kind of cautionary tale about how you can mean to do something good without recognizing the unintended consequences, bad consequences that may come out of it. And I think this is important for the Pharmacare debate. So what Ontario did, which in principle is a very good idea, is to say, you know what, we have a gap. Not everybody's being covered, we think. And so we're going to we're going to include all people under 25 in our public reimbursement system, because presently that's not the case. And we'll become the payers of first resort. And this is the key here. So in principle, that's wonderful. And indeed, there are some young people who had no access to any other coverage. And so that's a wonderful addition. The unintended consequence that no one expected was that as a result of the provincial government saying they would be the first payers, private insurers, and there are many young people under 25 who are covered often through their family coverage, their parents' coverage, a private coverage, no longer could immediately obtain that coverage. So it became quite a crazy kind of system where the young person would apply through the parents' private coverage. They'd say no, go to the provincial government. The provincial government would say no, we don't cover that drug because it's not on our list, because that's often what happens, is that there's basic coverage under the list, and then what's happening in the private is a top up. So they'd say no, then they'd go back to the private insurer, and the private insurer would say, we'll try to get it through compassionate access through the government. Then they would have to go back again, knowing perfectly well the government was going to say no. So, and then finally, after months of delay, they would get it through their parents' private plan, which is what should have happened in the first place. So I think, I tell this story because we need to be careful about unintended consequences of any administrative process that they set up and any policies they set up, so that we think about the unintended consequences before we get into a quagmire.
Yeah. And thanks, Louise. I'm sure that we can talk a bit more about that, and maybe just to add to that, when you think about the unintended consequences, run scenarios through in the real world, like what would happen if a mom with her kid goes to the pharmacy and asks for X, Y, and Z. If there were covered under another plan, I think there's a lot of lessons to be learned from OHIP Plus if Pharmacare goes forward at the national level. You're right.
Yeah.
So really briefly, the Health Committee of the House of Commons, after meeting with 101 witnesses, presented its report to the Health Minister and the House, called Pharmacare Now, Prescription Medicine Coverage for All Canadians. Shortly thereafter, the Liberal Party of Canada held its national convention in Halifax and adopted a motion, whereas the Liberal Party of Canada adopted a priority resolution to implement a national pharmacare plan, and that was a well-regarded and basically signaling that this may be a policy that could make it into the Liberal election platform next year. The government then formally launched a full advisory council on the implementation of national pharmacare in June of this year, so just early this summer, and we'll show you who the councillors are in a second. They've got a full year to report back to the health minister and the finance minister on their recommendations on how to implement, and that's really important. The main thing that Minister Petitpas-Taylor said was, we've got so many reports on why they think national pharmacare should be implemented. Now they're asking Dr. Hoskins and the councillors to tell them how it can be implemented. At the same time, and almost in parallel, the new Ontario government took power, and they have now, well, they announced that OHIP would become second payer, and they're actually moving to make that happen. I believe it's for April 1st of 2019, or March 1st, 2019, early next year. More recently, very recently, in fact, this past week, the Standing Committee on Finance issued its report to the pre-budget consultations to inform the government on 2019 budget, and it actually has a recommendation on national pharmacare, which I'll show you now, because we almost have dueling parliamentary reports on what should happen. So the Health Committee recommended that the Government of Canada amend the Canada Health Act to include drugs prescribed by a licensed healthcare practitioner and dispensed outside of hospitals in accordance with a common voluntary national formulary as part of the definition of an insured health service under the Act. So that was their recommendation to the government on how to implement national pharmacare. Half a year later, the Finance Committee comes out with its recommendation number 63, and they're recommending to build on the existing drug coverage enjoyed by millions of Canadians and follow a close-the-gap approach to pharmacare to ensure that all Canadians have access to prescription drug coverage, in addition to examining ways to provide catastrophic drug coverage. So keep that in mind, because as we go through the rest of this presentation and our discussion, you're going to see that there are sometimes two general approaches that we can talk about. One would be, universal public single payer, and the other would be allow Canadians to continue to have access to their private plan and either supplement that or, when it's actually not working, step in and make sure that Canadians are covered. And so with all of that going on, Ottawa is setting the stage for a 2019 election promise. Very likely, well, we know this is the new Democratic Party's position is universal single-payer public coverage. The Liberals are waiting for Dr. Hoskins to come out with their report, but you can bet that 2019 is going to see the Liberal government move forward in one way or another on something that has pharmacare in its name. And it's part of the health minister's mandate letter to work with the provinces and territories to make prescription drugs more affordable, improve access, and join with Canadians or join with the provincial governments to buy drugs in bulk, to reduce the cost that governments pay for these drugs, et cetera, and explore the need for a national formulary, which is potentially the infrastructure potentially of a national pharmacare plan. At the same time, there are many other things that the minister is doing that is supporting a more consistent approach to pharmacare across the country. They're making major changes to the Patented Medicine Prices Review Board. There are other webinars on that you can listen into. They're engaging in Health Canada regulatory modernization. So instead of just reviewing a product at a point in time when it comes out on the market, they're trying to take a life cycle approach and do 15 other things and many other things related to streamlining and making appropriate decisions about how to regulate the products, get them on the market, and then regulate them throughout their life cycle. And they're also, and this is a keep an eye on this point, they're making major changes to the Pan-Canadian health organizations, and that includes the Canadian Partnership Against Cancer that we did a webinar on very recently, as well as CADIS, the Canadian Agency for Drugs and Technologies in Health, Canada Health Infoway, all of the other C orgs, which we affectionately call them, because part of that report there was create a single Canadian drug agency. So, between now and next year, and certainly with the federal budget coming up, you can see that this government is moving forward. The question is, how does it tie in the concept of national pharmacare into all of these other things that they're doing? And meanwhile, the provincial political dynamics have shifted significantly. So if we showed this map in April of 2016, it would have been a lot rouger, let's put it that way. Since then, in the last 2.5 years, we've got the biggest provinces that have moved towards center or center-right governments in Ontario and Quebec. And even some of the Atlantic provinces are moving in that direction as well. The next election to keep an eye out for, of course, is Alberta's in May, and then all eyes, and in fact, Ottawa has really already started in many ways to prepare for the federal election, which is less than a year away. And what this map means is that when when Justin Trudeau took power in 2015, most of the premiers were really on board. It was hallelujah. The previous government's out because now we have an Ottawa that we can talk to that understands our language, who really wants to take action on the national front and do things collectively as a country. Now, Prime Minister Trudeau is facing a very different political map with provinces that may not be as interested in holding hands and singing Kumbaya on really challenging issues, including national pharmacare, which is very complex. But energy and pipelines is another issue, among many others that Ottawa is going to be butting heads with the provincial capital. So this is just something to keep in mind. Unless the federal government backs up a ton of money to the provincial capitals and says, "Hey, listen, we can implement this. Look how much more money we're throwing at it. Let's all do this in the national interest." I think that there's going to be a lot of questions asked from Quebec City and Toronto and Victoria and elsewhere to say, hey, what does this actually mean? And we've seen some indications on that already. Last year, it was the provinces that met at the Council of Federation meeting, and it was obvious that their support for National Pharmacare was shaky. They want to make sure that any federal program would come with an expectation of long-term and appropriate federal funding, and that participation would be voluntary. They don't want hard strings attached to it. They still want to keep control of their own design and delivery of public drug coverage. So this is a circle that's going to be really tough to square for Ottawa, and in fact even for Dr. Hoskins and the council to come up with the right finessing solution to figure that out. Now that said, Dr. Hoskins, as chair of the advisory council on the implementation of National Pharmacare, has got a really strong team behind him, and they've been meeting across the country. And I'm going to ask Louise to just give us a quick snippet of her thoughts on the meetings that she's participated in. But the very diverse background of counselors, from people who are experts in health equity, who have lived in patient experience, health informatics and health information, Indigenous health, a political background, and finance. So really a very interesting, and we think a very thoughtful choice of counselors. And so we're optimistic on that front that whatever they come up with is going to capture or at least reflect some of the nuances. But Louise, what do you think about your interactions with the council so far?
Well, I think they're all well-meaning. I mean, Camille Orridge, for instance, has a very good, strong sense of social determinants of health and the challenges. Vincent Dumais is also someone who's been a patient for a long time, and he understands the systems very well. I think, that there's, we have some finance experience, John Wright, and so on. I think everybody on the council is well-meaning. I think they're listening hard. However, I think they are stuck with a very difficult political and economic landscape at the moment, and I think that is going to be very challenging in terms of the way they develop their report. I think that they have so many masters that would like to be served in this process. It's going to be very. I don't envy them this job at all.
Yeah, and you're going to get into that in very shortly around some of the politics. I just want to situate our listeners on the Pharmacare timeline briefly in terms of what's happened. They've been meeting with people across the country, so many meetings. It was actually really impressive. Every territory and many of the regions as well. Many of the people on the line and the Survivor Network, and you actually led a really comprehensive submission to the Advisory Council that went in last September. We're expecting an Advisory Council interim report that will not be made public, but that will be presented to the federal health and the finance ministers. Just one thing to circle and keep in mind, the federal budget. There's right now additional consultations happening on the federal budget led out of the finance ministry. There's some questions in there that are on or that relate to Pharmacare. So there's some really strong indication that the next federal budget, which will come down in February or March, we don't know when exactly, that there could be another Pharmacare element to that, and that would allow the government to get well ahead of the publication of the Hoskins Council report and basically say, look, we couldn't wait, we wanted to do something, and so we can speculate on what that might be a little bit later, Louise, if you'd like. But the report is due no later than June 2019 publicly. And of course, the federal election is in October. If you want to really stretch this out, if there is an implementation plan, we're probably not going to see anything until 2020 or 21 in terms of actually getting into the hands of Canadians. Really briefly, two potential approaches. We've already hinted at it. One is a first first payer, and from the public plan, you can imagine everyone having the same card, or at least if the different provincial cards having access to the same plan. It could be implemented maybe by an expansion of the Canada Health Act or similar legislation. There's been some ideas about the Canadian Pharmacare Act. It has significant stakeholder support among especially unions and academics, among others. Pros and cons, it's potentially expensive, and it really comes down and depends on the plan design. But a lot of the analysis that we've seen shows that there would be a shift of who would pay for this from the private sector to the public sector. So really, whose wallet that will come from and pay for would probably land on taxpayers and employers, et cetera. The other approach is the mind the gap approach, the targeted approach. It would aim to address the coverage gaps while maintaining that access to the private drug plans that we've talked about earlier. It also has significant stakeholder support across the country, and I think that's something that the Advisory Council heard a lot from, especially from patients. And if you look at what that means in terms of finances, less public spending would be required, most likely under the targeted approach. And in terms of orders of magnitude, you're looking between $9 and $10 billion for the single first public payer. That's what some estimates have. And the targeted approach could be as low as $1 billion to $3 billion, depending again on what exactly you do. So with that, Louise, I'm going to turn it over to you. Bring us through some problems, barriers, and the reality, and then we'll have some Q's and A's.
All right. Well, first of all, I would like to thank CCSN for inviting me to join Bill in the last webinar of the year, and also to wish all of you a good restful holiday, because you're going to need it. Next year is going to have lots of interesting things for us to do. So I want to start out by talking a little bit about problems, which seems to be, I guess, my job description is problems. I went to a number of the consultations. I got to a couple, a town hall and a consultation out in BC. I was to several consultations in Toronto. I've received reports back from consultations in other parts of the country. So I have a pretty clear idea of the things that were said in the room. And I think it's important for me to kind of give you a sense about that first, because when I think about health policy, I always ask myself, what problem is this health policy trying to solve? And the interesting thing about this health policy is that everybody has a different idea of what problem we're trying to solve here. And that's a problem in and of itself. Because if there's no clarity amongst the stakeholders about what they're really, wanting to do, what they're trying to fix, then you're going to get a very muddled kind of response to the solutions will be muddled, and the solutions will certainly not solve much at the end of the day. So what did I hear from people in the rooms? And these are multi-stakeholder meetings. Some of them were patient-only meetings. So some people want to just get rid of private insurance. And there shouldn't be any more private insurance. Well, maybe you can buy a little bit of extra if you want to, but everything should be covered through the public system. I heard some people say that. I particularly was surprised to hear union groups say that. And when I asked them about this, I said, first of all, doesn't that kind of take away your raison d'etre? I mean, isn't the deal that you go and negotiate better contracts with better benefits, like drug benefits, than what they could get for themselves? And also, what would ever make you think that the public system is going to be able to cover all of the drugs that you often can in some very gold-plated drug benefit packages? And I didn't get a very clear answer, except to be told, oh, no, our expectation is that the public system will mirror, what we've been getting in the private system. I just can't imagine that that's going to happen. Although I would tell you that I would be delighted if it would. I think National Pharmacare is a great idea. And I think if we could, in fact, ensure that everybody had the best public plan that we presently have in some of the private plans, dare I say some of the federal government employee private plans, then I would be over the moon. But I don't think that's a reality, and I was really kind of surprised that anybody thought we could get there. I heard some people say we need equity. Let's solve the equity problem. So when I asked them what people meant by equity, they meant it's not fair that in Ontario we can't get oral cancer drugs paid for, but in British Columbia we can. So everybody across the country should be able to have equitable access to the drugs that they need, and one province shouldn't be doing better than another. That also is a very laudable goal. Often the Quebec model is mentioned as the right model because it seems to have the most drugs covered, and it also requires both public and private coverage, some kind of coverage for everyone. But I personally don't know that we're going to get there either. Another thing I heard was equality. Let's have equality, which is different than equity. Equity is about fairness. Is it fair that some people get some things and other people don't get it? Or is it fair that that I need a drug and my government won't pay for it, but another government will? Equality says, at least let's make sure that everybody can get the floor, a minimum, across the country, and that everybody's getting the same thing across the country. And some people would be happy with that. And the question I always ask them is, okay, so you're saying that you want to be sure that everybody in Canada, wherever they live, can get the blue pill. This is my way of describing it. Everybody gets the blue pill. Yep, that's good. And then I say, well, what do we do about the people for whom the doctor says, unfortunately, for your disease, the blue pill isn't going to work. You've taken it before, you're resistant to it, or it has things in it that are not good for you and you're going to have adverse reactions, or we know that for the kind of problem you've got, you're just not going to do well with the blue pill. So I ask, what do you do about the people who need the green pill? And that equality will not solve that problem. Equity might, but not equality. And then other people say, well, we're worried about that 10% across the country who have no coverage at all. And we just want to make sure that whatever is available in a particular province, that there's nobody who doesn't at least get that minimum. So those are very different goals. Even from the public. The public doesn't really know what it wants in pharmacare, or let's say that members of the public have different perspectives about what it should be. Everything, as I say, from it's going to be the most gold-plated thing in the world, it's going to be the very best drug coverage, everything you need and want, everything that's ever been negotiated for the very best private plan in the world, to, well, could we at least just, fill in a few gaps, and everything in between. So as I say, that's why I don't think any of us really knows what we want. At least we all want different things. So that's going to be really a tough story for them to kind of, whatever they do, other than the gold-plated solution, which is not going to be the one we're going to get, they're not going to make people happy. So let's then talk about the barriers to anything, to any movement on pharmacare. First of all, Bill mentioned the Canada Health Act. I am amazed, candidly, I'm amazed that anybody would have made a recommendation that the federal government should open up the Canada Health Act and add drugs. I think the chances of that are less than minus 150, because the minute first of all, opening up a piece of legislation is a big job. It means things have to get through Parliament. That is a huge job. And the problem with that is that you can't just open up the Canada Health Act, say we're going to open it up and add drugs, and that's it. The minute a bill gets in front of Parliament, people can throw in everything but the kitchen sink. So then, the veterinary people will say, well, you should include payment for drugs for animals, and the physiotherapists will say, well, you should include payment for physiotherapy fees. And the minute you open up a piece of legislation like that, you are opening up a big can of worms, even if you don't intend to. So I don't think there's a hope in the world that that's going to happen. And unfortunately, we are, without that change, we are stuck with the jurisdictional divide of the federal government making certain commitments for universality in terms of doctors and hospitals, and the provinces getting stuck with universality of drug coverage outside the hospitals. So what does that mean? Well, that means that we don't have one decision maker even talking to the federal government about what pharmacare should be. We have many decision makers. Every province is a decision maker in essence. And yes, it can be voluntary, and people can decide to opt in or out, which has been a solution proposed. The difficulty with that solution is that, with all due respect, it will be the provinces that have the least that will probably be willing to sign on, and that's not going to make for a very robust universal pharmacare program when a lot of the big provinces don't join in. So, we have to accept that each province does have different resources and different priorities for its budgets and its health budgets. And so it's not really going to want, as Bill mentioned earlier, is not going to want the federal government to say, here's what should be your priority. We'll give you some money, but it's got to be used for this. Provinces don't like this. And they particularly, as Bill mentioned, with the world going the way it is provincially, even if the federal government has a good idea, there are provinces that won't accept it because it's an idea from the federal government. Let's just face it. So I think there's another problem with getting a very robust national pharmacare plan, and that is, and this is my opinion, there isn't really a profound interest in health at the federal level. I'm sorry to say it, but I don't see it. And I kind of understand it, because you don't really get a lot of political points, even votes, for doing much at the national level with health, because it's such a huge issue, and the provinces really do end up implementing it. So, whatever you do, it's never enough. So I don't think it's huge. Now we know that the transfer payments also to the provinces are down. So where's the money going to come from? Are they going to increase the transfer payments to do this? Not sure. And there's generally a lack of money. I just don't think that we're in a time where a priority for any governments, sadly, is health. They have other economic realities. And certainly another big barrier to the federal government taking on National Pharmacare is the fact that they don't have a very good track record in administering systems. So the Phoenix pay system, which they implemented, has been the biggest boondoggle and profound cost to the public taxpayer for a long time. And Nick Nanos, of Nanos Research, recently did a poll of some Canadians, and they expressed in the area of pharmacare, quite a number of them expressed a sense of lack of trust for the federal government in running programs. So that's a problem. So what about solutions? What about the reality of solutions? Maybe we can go to the next slide, which is my 5E slide, Bill. And I call it the 5 E's. So what could we do? If we want to talk about the reality of what we could do, here are some of the things we could do. First of all, what we can't do is get rid of private insurance. It's just not going to happen. We already, as I mentioned earlier, the program in Ontario, OHIP Plus, proved that we do love our private insurers, and we're not going to be getting rid of them. And I don't think there's been a lot of talk about a list. It'll be this list of drugs. I can't even imagine how long it would ever take to get an agreement to any kind of a list of drugs, unless the federal government is merely going to pick a list of drugs like the drugs in the World Health Organization, which is really going to take us nowhere, because almost everything there that people would need in Canada on an ongoing basis is probably already covered. So that's what's not going to happen. So what could happen in the 5 E's? So we could get, one thing the federal government could do easily, in my opinion, is create equality. Now, by equality, I mean that everybody gets access within their province to what is on the public system. And Bill mentioned that everybody generally in Canada, most people do have access to the public system, but that's actually not practically accurate. It's theoretically accurate. So in Ontario, we do have the Trillium program. And theoretically, anybody in Ontario can join the Trillium program, and they will get reimbursed for drug coverage. The difficulty is that there is a copay which is required, and it goes up depending on your income. I know factually that there are many people who have never joined the Trillium plan or do not use the Trillium plan because they cannot afford that first deductible that they need to pay. So one thing that the federal government could do that really wouldn't be complicated, wouldn't require new administration, nothing, would be to say to the provinces, we will be willing to give you enough money so that there is nobody in your province who does not practically get access to your program. So please remove the deductibles from the people who are basically the working poor, or please remove age discrimination requirements and ensure that everybody in your province practically can get access to whatever your program is in your province. That would be simple. It would not probably even cost all that much money, and then you could get some equality at least within each province. Now, then we move to equitability, which is quite different. Equitability is about fairness, and there's two ways of looking at fairness. One is it fair that I can get something in Ontario that I can't get in BC, or more likely, is it more likely I can't get it in Ontario and I can get it in BC? So they could say, look, certainly for cancer drugs, it's not right that everybody except Ontario and some Atlantic provinces can have their oral cancer drugs paid for. We'll top that up, whatever that would cost you, provinces, to make sure it's equitable for everybody to get those oral cancer drugs. We'll pay for that. That would be pretty simple. The other thing about equitability is the question of the blue pill and the green pill, as I mentioned earlier. And they could do some work on that too, to say, look, we'll set up a sort of special access program for people who fall through the cracks, who you're giving them the green pill, blue pill for arthritis, but in fact, it turns out these folks, few people need the green pill. And they could certainly be a safety net for that. The third E is ease of administration. I do not think that the federal government is even honestly contemplating setting up its own administrative function. At least I don't think the people in finance want to do that. So it should be pay for the administration under the existing provincial system. 4, another reality, and I've mentioned this already, is just the economic environment that we're living in. I just don't think that there's a lot of money and an appetite to go into much more deficit to do much in health. And the last E is elections. And actually, it's the most important E of all. We have a very mixed palette across the provinces, but generally small c, conservative thinking, and some of them conservative governments. And we have a liberal federal government. So that's a problem. We're going to be in probably potentially worse shape after the Alberta election. I'm not predicting, but we could be. And friends of mine who live there say we will be. Maybe they're right, maybe they're not, depending on what you think worst is. And even the federal election is going to be no cakewalk for anybody. And that is really a problem. So I would predict that the federal government in this federal election will talk about pharmacare. That will be its health platform. It will continue to not explain which of the E's it's actually dealing with, what it's really going to be doing in practical terms. And I think they're just going to try and skate by with very, very broad brush ideas. And I think indeed that that's what we'll see. And I think that when Bill talked about the finance proposal for what should happen versus the HESA proposal, I think it's the finance proposal that's going to prevail, which is going to be a very broad brush, non-specific kind of pharmacare going forward. And then, of course, there's the whole question of if the Liberals do get in, will they even have anybody to talk to about implementing it? Because I don't think the provinces have a huge appetite to have that conversation. So that's not a very happy end to probably the year 2018. And I'm okay if I'm wrong. I've been wrong so many times before, one more time won't matter. But that's kind of the way it feels to me right now.
Well, thanks, Louise, and I'd encourage people to start getting your questions ready. I'm just going to give a comment on 1, 2, and 5 among that, maybe to add to it. So number 1, on the equality, just a note that British Columbia over this past year has now canceled premiums and deductibles for British Columbians that make less than $30,000 a year, or households that are relatively poor, basically making their system more progressive and doing what you suggested that should be done at potentially at the federal or national level. So some of these innovations actually can happen within the provinces, and hopefully more provinces will do that to tackle that issue of equality, especially for Canadians who are basically at or below the poverty line, and those who are, as you said, the working poor. On number 2, in terms of equitability, and that's a big distinction between equality and equity. One program to keep an eye on that most of the provinces have something like it, and it's the exceptional access programs, and especially the Passion d'Exception program in Quebec. It's a separately administered program. And remember in law school, Louise, we learned about the courts of equity. If something, is going through the common law, that this is the way that the law says it has to happen, you could always appeal to the king, right? And that was the courts of equity. And the idea was fairness there, what actually makes sense in reality. And so having that escape valve, or that opportunity to apply for access for a product, even if it's not on a formal list, even if it's not indicated for this disease, but there's clinical evidence that shows that this might actually work or be helpful. We still need that level of fairness, or that opportunity to get access, and that's something to keep an eye on for number 2. And then for number 5, in terms of elections and what might come next year, and I'd love to get your reaction to this. When I actually got called to the health committee as a witness on its study on National Pharmacare, and I suggested that the fact that all of the provinces and the federal government are negotiating the terms of reimbursement with the manufacturers, that is the essence, or the infrastructure of a National Pharmacare program. Now, it's not a National Pharmacare plan in that everyone has the same card across the country, but the terms for all of those plans across the country are negotiated by that body and through the Pan-Canadian Pharmaceutical Alliance. So one TBC issue to watch out for in 2019, especially around the budget, is could the federal government simply bolster the Pan-Canadian Pharmaceutical Alliance and then check that box and say, look, this is a National Pharmacare program that Ottawa is now supporting more significantly than it was before as a real junior partner. It's going to really inject some funds into making those negotiations happen faster and better and improve affordability and accessibility. So maybe there's something that we haven't seen in one of the official big reports that Ottawa could do that would be a step on the road.
Yeah, I don't. The problem, that's a great idea, and I know that I'm a big supporter of the PCPA. I think the difficulty is that doesn't really sell as a political campaign. I don't think the PCPA doesn't roll off the tongues of your average citizen. So I don't know if they would make the connection to doing that as being the universal pharmacare they thought they were getting.
No, you're completely right. It would actually potentially preempt the Hoskins Council report, so they could say that they are moving in that direction without biting off more than they can chew. Which arguably, and I think you hinted at that earlier, OHIP Plus was biting off more than the provincial government could chew, and there's a lot of lessons learned there. This would be an incremental step towards more consistency of the drug programs across the country, and it could be something that the provinces would not balk at as fast as something that would be more what a lot of the first payer provincial or national public plan would want. So it might be a Canadian solution, even if it's not as saleable politically.
Yeah. Oh, yeah, I think so.
But anyway, so we got some a couple of good questions that have come in, and just keeping an eye on time, we only have 2 minutes left. So for those of you with quick fingers, get them in. We've got some questions we could actually put up here. You've said and actually, Louise, you've been involved in writing a bunch of submissions on behalf of patient organizations, and a special shout out as well to the Health Charities Coalition of Canada, and Connie Cote and all of those groups who have come up with some very clear principles that they would like to see in anything that moves forward that includes patient-centeredness, equity, et cetera.
Can I just put a quick pitch in that tomorrow is the last day to make submissions for what they call the refreshing of the Canadian strategy for cancer control. And I have been working with a number of groups that are putting in a joint submission. If there's anybody else on the call who's interested in that, because that's related here as well, the whole issue of how cancer should be managed federally as a strategy, which links into pharmacare. I'd be happy to show people what we've come up with, and if they're interested in joining in the submission, we'd be delighted to have them.
That's a great point, and it actually brings it back to cancer as well, which is of course what the CCSN is about. Maybe on that point, I'm just going to quickly flip back to your contact information. If anyone wants to get in touch with Louise, there's her email, and offline, of course, through. And I'm going to flip ahead now to the Canadian Cancer Survivor Network contact information. We really, and the network really depends on all of the listeners and other people in the community interacting with us to give us ideas about what we could talk about next. On that cancer control strategy, we did a webinar on that I think 2 weeks ago to let the community know about the opportunity to provide input. And yeah, tomorrow's Friday. That's the end of formal consultations. Get something in there. There's even a hashtag that they're using to encourage discussion. But the organization that's running that is called the Canadian Partnership Against Cancer, so CPAC. So have a look at that. And Louise, thank you for taking the lead on and drafting that on behalf of a whole bunch of groups.
My pleasure.
Yeah. Any final thoughts, Louise, before we close it off and we give the conch back to Allison to send us off?
Well, I think it's the thing that I want to say to you is keep talking about this question of pharmacare, and particularly the federal politicians who are going to start knocking at your door, and ask them, what do you mean by this? You say this is your health strategy. This is what you're running on. What are you actually going to be giving me in National Pharmacare? Because I think that's a question that people don't ask enough. And we all work on the definition that we want and think that that's what everybody else is promising us. I suspect you might find that there's quite a disconnect between those two. So keep following, really, really talk to your politicians about this.
Excellent. And that's what a lot of 2019 is going to be about between now and next October. So thank you very much. As you said, Louise, you helped kick off the year of 2018 in terms of these advocacy webinars and these policy webinars, and just thrilled that you're able to close it out with me as well. And special thanks again to Allison for making the technical aspects of these webinars work so smoothly, and everyone at the Cancer Survivor Network for all that you do. Looking forward to next year, but in the meantime, I hope everyone gets a wonderful break, and we'll see you hopefully early in 2019.